Hey, hi everyone, and welcome to Obesity Management Echo Session for the month of July. Finn and Darren, is everybody in?
Yep, you can get
Yeah,
started,
you can go
Rebecca.
ahead. Okay, great. So thanks everybody for joining. Today is our seventh session of the year, and our topic for the didactic portion of the presentation is pharmacotherapy and obesity management. And we have Dr. Katherine Morrison joining us today. So thank you, Dr. Morrison, and I will introduce you guys a little bit later. But first, just a few reminders. These sessions, as we know, are only really effective when we participate. So a reminder to turn on your cameras, wave hello, raise your hand if you have questions, type in the chat box, unmute yourself, whatever you would like to do to participate. It all works out on our end and we love it. And then of course, the other way that this works is that we have patient cases submitted. So I encourage you guys to kind of reflect on your caseload right now and think about if there are any cases or patients that you think would be appropriate for an echo discussion. I'm currently booking cases from next month, August, all the way to the end of the year in December. So if you reach out to me, you can pick which month works best for you, which is a little bonus. Otherwise, I come around and request cases and then we kind of get stuck with some dates sometimes. Okie dokie. And next reminder is that the session will be recorded. We do share, so as a result, we ask you not to share PHI and to mute when you're not speaking. So we'll do a quick roll call. If everybody could just head over to the chat box and say hello, who you are, what your profession is, where you're coming from today. And while you guys do that, I will go ahead and introduce our speaker for today. So as I mentioned, we have Dr. Katherine Morrison joining us, and she's a pediatric endocrinologist and professor and associate chair for the research in Department of Pediatrics and the co-director of the Center for Metabolism, Obesity, and Diabetes Research at McMaster University. She's a clinician researcher and is the medical director of the Pediatric Weight Management and Pediatric Lipid Clinics at McMaster Children's Hospital. Her research is centered around the etiology, consequences, and treatment of obesity and lipid disorders in children. So thank you for joining us today, Dr. Morrison, and we'll be doing questions after the presentations. But in the meantime, if you have questions throughout, you can put them in the chat box and we'll get to them at the end of the presentation.
Great. Thanks very much, Rebecca. Hi, everybody. Great to have everybody here at lunch. This is a big topic, and I'm going to try not to go too quickly. But really what we want to talk about today is something that is on a lot of our minds as we see new studies come forward, and that is, what is the role for pharmacotherapy in pediatric weight management? And I've been a bit provocative and asked, is there a role? I do have some disclosures I need to make you aware of. You'll see those there, both with Novo Nordisk and Novartis. The Novartis is not related to obesity, but the Novo Nordisk work is. And I will be trying to present all of the medications that are current pediatric data available in order to mitigate any potential biases. And these are the learning objectives, which you would have seen already. So hopefully you'll come out of this, and we'll all come out of this with a sense of what the current literature is, and also a little bit of conversation towards the end as to what we're all doing currently. So I'm going to talk about the agents that target energy balance and have published data in children or adolescents showing efficacy in anthropometric, cardiometabolic, or other health outcomes. I am not going to talk about the efficacy of agents, for example, for the treatment of hypertension, or for the treatment of diabetes, or for mental health issues in a population of children with obesity. And while it sounds like a fine line, I think it's important to understand the difference as to what I'm actually going to address today. So there are 4 medications that are currently in discussion in terms of the use of them in pediatric weight management. The first one is one that's been around for a long time. That's orlistat. All of the slides for each of these four will be very similar. So I'm going to begin with just introducing the class. Orlistat is the gastrointestinal lipase inhibitor. Essentially, it prevents you or reduces the absorption of dietary fat intake. And here I'm going to sort of summarize either whether this meta-analyzed data focusing on most recent studies, or if there are single study data available only. Orlistat here, we're looking at the efficacy on anthropometric outcomes, but you'll note at the bottom that I've mentioned that there is some comment in the manuscripts available around lipids, around glycemia, and around blood pressure. So I'm presenting today the only meta-analysis I could find, which surprised me, of orlistat. There's only 2 studies that are published. Really, the vast majority of the data is from one study by Shenwan et al. And there's a total N, and these are randomized control trials. The total N includes both the exposed and the control study population. The age group was anything over 10, and the average in the 2 studies was somewhere between 14 and 16 years of age. Important to note what age group, what populations they've actually been looked at. The population was in children with obesity, and the outcomes included, as I said, other metabolic outcomes. The dose is there, and the duration is up to 1 year, so not super short term. And this is the meta-analyzed data. And for those of you who aren't familiar with looking at forest plots, on the left, you'll see that this looks at pharmacological and behavioral. So this was pharmacological added to behavioral, and the control group had behavioral interventions alone. The 364 is the total number of treated with medication. The 198 is the controls. And as you look over to the right, you will see this diamond here, which essentially shows the impact, with 0 being, the dotted line in the middle being no impact. And the fact that that diamond does not cross suggests that there was a decline in BMI. So there's a decline in BMI in this outcome study, but it's relatively minor, minus 0.55. The summary is that the change, and I've put both the BMI and BMI Z-score, I've tried to be consistent with the anthropometric outcomes that were presented. This is a standardized mean difference. So this is not a change in the actual BMI, but in the number of standard deviations. And you'll see that it's of -8. That suggests that there's almost 1 standard deviation of decline in BMI from baseline, more in the treatment group than in the control group. And the change in the BMI Z-score standard mean difference was 0.43. Okay. I mentioned that they looked at other outcomes. They did not note impact on lipids, on glycemia, or on blood pressure. Really important to note that the vast majority of kids in this trial did not have abnormalities in those at baseline. What about side effects? Important to think about that when we're trying to weigh what we're going to do. There certainly are side effects with this medication. They are largely gastrointestinal. The bloating and the GI upset are relevant. Fecal incontinence is, for many kids, a game changer for this medication. It only occurs if they continue to have a reasonably high dietary fat intake. But it certainly is a challenge for our adolescent population when it occurs, and has impacted the use of this medication. Okay, so using the exact same setup, I'm going to talk now about metformin, which has also been around for quite a long time. It's obviously used in the management of type 2 diabetes in children. It is in the class of biguanides. In fact, I think it's the only one of this class that's still on the market. And we have more data here. This is most recent meta-analysis that I could see that was published in 2020. I will tell you that we are in the process for the clinical practice guidelines. We have just completed a systematic review and are in the process of writing up that paper, but because it's not published, couldn't include it today. But that will be coming in the very near future, and it will look at all medications. Metformin, were greater than 38 studies identified with a total N of greater than 2,000 study participants. You'll note the age here is slightly younger. There are some studies that have been done with metformin in younger population, but the mean age is about 13 years. This one has been looked at in children with obesity, but also in several other conditions, insulin resistance being the most common, as well as in PCOS and in NAFLD. The dose has to be titrated up and has varied somewhat. The end dose has varied somewhat, although the most common, I suppose, is probably about 2 grams a day with 1,000 milligrams BID. And the duration has been from fairly short, 12 weeks, up to actually 192 weeks. So that's a lot of data. And again, let's look starting on the left. These are forest plots when you have more studies. And so each line is a study. And if you look at the bottom, you will note that, again, we have that triangle, which is a summary overall of the change on BMI on the left and on percent body fat on the right. And that there, again, is the meta-analysis favors that there has been an improvement or a decline in BMI. If you look on the right, you'll notice that there are fewer studies, and essentially they are consistent that there is a decline in total body fat percentage. And so what are we looking at in terms of the change? This has been presented slightly differently in this paper. It's not standardized mean difference, but it's the difference in BMI. So there was a greater decline in BMI in the treated group, minus 1.0, and the 95% confidence intervals are there, than in the placebo control group. Most of these studies have been done in conjunction with children or adolescents who have obesity but are also receiving lifestyle behavioral therapy, though it varies from one to the other. And you'll notice that there is also a mean difference in the total body fat percentage with a decline in body fat percentage of 1.62. So this is significant. The clinical significance is something that we can chat about. Generally, I'll come back to that as we move forward. There is also pretty clear evidence of a reduction in insulin resistance. And as I mentioned, this is the one medication in which a significant number of the studies have been done in children that have an abnormality in that metabolic outcome at baseline, and that is very true for insulin resistance. This is also associated with some nausea and GI upset, which often can be managed through a titration up to dose, but is certainly present in a number of children. Okay. GLP-1 agonists are something that we've heard a lot about. We will continue to hear a lot about in the coming weeks. Coming months, I should say. I'm going to present the study that is the largest study published as a randomized controlled trial in children and adolescents, mostly in adolescents, and that is of liraglutide. It is a single study I'm presenting. There's a total N of 251 study participants, and their mean age was 14.5. Entry into the study was for children 12 and over only, so less experience with the younger children. than there was with metformin. This was a study in children with obesity. The dose, they titrated up to a dose of 3 milligrams. And please note that this is not an oral dose. This is delivered subcutaneously on a daily basis. And it was for a little bit over a year, this particular study. And I want to walk through, this is a busy slide, but I think this is a more recent paper. As you can see, it was published in 2021. And what you'll note is that there's been sort of an advancement in the way that the data is actually presented. And so beginning in the top left, you'll note that they now present the BMI standard deviation or BMI Z scores. And the blue line essentially describes what happens to the BMI Z score over time as the mean, and then the little brackets on each side of the dot are the confidence intervals. And you'll see that there's a gradual decline in liraglutide, probably peaks somewhere around 40 or 42 weeks after randomization. After 56 weeks, the medication was stopped. And you'll note that the sort of lowest mean change of BMI Z scored was 0.3. And then when the medication stopped, that the BMI again increases. So this doesn't permanently change energy balance. If you're looking on the right side for the relative change, so this is the percent change, and this has become much more, folks are much more interested in this because there's some suggestion that a relative decline of 5% or 10% are important cut points to be looking at impacts on health that are considered by many to be clinically significant. You'll note that the mean change from baseline in BMI was around 5.5 or 6%. And I want you to now look at the bottom two graphs, which are quite interesting, because what they talk about is the variability in change. So you've seen the mean changes in the two graphs on the top, but there's a lot of variability. You have a participant who's had a 35% decline in BMI on the far left here. And even amongst those treated with liraglutide, some have continued to have an increase in their BMI. So it isn't efficacious for everyone. You'll also note the percentages of those who've had a 5% and 10% decline in BMI. The 5% was 43% in the liraglutide group compared to 18.7% in the placebo group, and 26.1 versus 8 in the 10% reduction. So there's a significant number of study participants who had a decline in their BMI. If you look on the left at the impact on BMI Z score, the mean BMI Z score change was 0.23 and the mean BMI change was 1.39, which is slightly more than what we saw with metformin, which was 1.07, I believe. Okay. I cannot advance the slide. Thank you. So again, there was no significant change in fasting glucose, in hemoglobin A1C, or in blood pressure in this study, though they were measured. And again, they note that there's a relatively low proportion of individuals at baseline who had abnormalities in these. Nausea and vomiting are also present in children managed in this study, more so in the liraglutide than placebo group. And important to note that 10% actually discontinued the trial as a result of this side effect. All right, can you advance my slide, please? Thank you. The last medication I'm going to talk about is setmelanotide. This actually impacts your central appetite control. It is a MC4 receptor agonist and suppresses appetite, or is hypothesized to suppress appetite. And next slide, please. has been studied in 2 open label trials. So this is a different ball of wax we're talking about here. This has been looked at in phase 2 and phase 3 trials, specifically in children with a genetic abnormality that impacts their appetite control relating to the POMC pathway. 6 with POMC deficiencies, 3 with, these are the pediatric patients, 3 with leptin receptor deficiencies, and 6 with Bardet-Biedl syndrome, published in a separate study, but essentially was done in the same way. These are younger, age 6 and up. These children had severe obesity and had to have deficiency or class or diagnosis of these conditions, one of those conditions. The studies are brief, they're 12 weeks. Next slide, please. And I want to walk quickly through this data. On the left is the study published by Clément in Lancet Diabetes Endocrinology in the fall of 2020. They've presented individualized data, and they have not separated the adult and the pediatric data. So this is all comers that are being presented here. The red square is the mean of the entire group. And you'll note that they had the 12 weeks, and then they had a withdrawal period, and then they extended out to 52 weeks in this open label trial. There is no control group per se. And what you will note is that the composite mean, certainly for percent change in body weight, does go down, with now about an 18% decline in body weight. And they have not presented BMI data in the same way. And you'll note the follow-up for the number of participants are along the bottom, so all 10 participants were followed up to 52 weeks. And you'll see that their changes largely persist, other than that withdrawal period where there's evidence that it gradually goes up. The graphic on the bottom are in children with leptin receptor deficiency, and you'll see that a somewhat lesser impact in terms of the total decline in body weight, but still with, in most individuals, or in many individuals, a decline, although by 52 weeks, the 4 individuals who were still in it, really, there was much less of a decline than had been previously seen. There is some splay in both of these. You'll see that there are individuals who don't respond at all, if you look both in the POMC deficiency and the leptin receptor deficiency. And then on the right is a very small number of individuals that have been presented in this open label trial looking at adults and children with Bardet-Biedl syndrome. 8 individuals had their body weight change from baseline looked at out to 1 year. And you'll see the change in body weight demonstrated there. This is actual change in weight in kilos. And at the bottom is the percent change. Sorry, it is the percent change. My apologies. So it's the relative change in weight. So around 15%-ish at the mean change. And I was intrigued and wanted to include the hunger scores, which they've included here, noting that there was considerable decrease in hunger amongst these folks with Bardet-Biedl syndrome. Next slide, please. They have also published a subsequent paper just recently where they did demonstrate in a subset of the individuals with POMC and leptin receptor deficiencies improvements in quality of life. So this is suggesting that there's improvement just beyond the anthropometric, that it is impacting how folks report on their quality of life. Important to note that there are some side effects. That 100% of participants have had injection site reactions, and hyperpigmentation is prevalent in 80%. And you'll notice this is really quite notable. These are the changes after treatment, before and after treatment, after 1 year of treatment with this medication. Next slide, please. So that's a very quick race through. I would love to have a discussion about how you guys see this use of pharmacotherapy, and I'm happy to address any questions. I think we all have a lot of work to do to figure out how we best fit these medications into our treatment paradigms. That's it.
Excellent. Thank you, Dr. Morrison. We appreciate that presentation. We have a couple of minutes for questions. So if you have questions, please raise your hand, unmute yourself, or type them in the chat box. And while we are waiting, I'll just take this opportunity to let you guys know that Sick Kids is actually conducting 2 clinical trials right now on setmelanotide in patients with rare causes of genetic obesity. If you think that you have a patient, pediatric or adult, could be family members of the patient. If you think you have a patient who may have genetic obesity, please be in touch with me. We can get them tested for free. And it's a very quick test. Actually, the results come back in about 3 weeks. And we can take it from there. And I'll put this in the chat box.
That's excellent, Rebecca. I was going to ask you specifically if you guys were involved with those trials. Can you just clarify for everybody else the age of the population that you would be recruiting and the conditions? Are you doing the Bardet-Biedl study is actually one of my specific questions.
So we will be doing the Bardet-Biedl. The sponsor is making amendments to the protocol right now. So that's been put on hold, but it's coming probably in later this year. We're doing 2 other studies, and there's a whole, there's I think 30 different genes that are eligible. And it's pretty specific conditions. So it's good to get them tested, and then we send those de-identified results to the sponsor to confirm eligibility. And it's any patients or people who are age 6 to 65.
Terrific, thanks.
Great.
Sarah?
Yeah, I'm going to ask another question before I forget about the study you're talking about. Is there an easy way to get genetic studies done on some of these patients? I've applied for the monogenic obesity panel before myself, because it is hard to get a genetics consultation in a timely fashion, especially now that there's treatments available. So if there's an easier way for us to do that, that would be good to share so that we can get more patients for you potentially. So maybe some criteria for who deserves genetic testing, just so it's on paper, and an easier way to get through the system without having to necessarily see a geneticist, kind of like we do for microarray testing.
Certainly, I can send out an email to the group with a summary of that information, but we are going through a private company called Prevention Genetics, and it's fully covered by Rhythm Pharmaceuticals. And it's a buccal, like a cheek swab, and it can be sent directly to the patient's home, and they can pop it in the mail, or we can send it to your clinic if it's easier
that would be great
on site. I'll send that information out.
And then with respect to the talk, thanks so much, Katherine, for talking about that. It's been high on lots of our minds for a long time. I have gone a bit off label at times by extrapolating the liraglutide info to semaglutide, which is Ozempic. And it's interesting. It's interesting because there is some research on semaglutide too in pediatrics. There's some stuff there, and it's a little bit easier as a starting point and with ODB coverage, et cetera, for some people, although I think the age 18 cutoff has become more of an issue. It works in some kids, and then just like you say, in others not. And so then when you do have a question, I imagine that some kids eat for different reasons, not necessarily because they're hungry like the rest of us. And so then I get to a situation where I have a kid on, let's say, one of these medications, and they're still gaining. And the question is, when I stop it, are they going to gain even more? Because maybe it is doing something, but just not enough. Where there's other people who do quite well on even metformin or semaglutide. I have a couple on liraglutide too. It's just you can't really get it covered through even EAP. I've tried before because it's not registered with EAP or something like that for exceptional access. So just appreciate your thoughts. I kind of just have extrapolated a little bit, and the once a week introduction to sub-Q injections sometimes helps.
Thanks for that, Sarah. There's a fair number of questions there, and there are issues that we maybe should arrange to have a provincial conversation about this, especially once our guidelines come out early in 2023, because first of all, the semaglutide study is not yet published, and so that's what we're all waiting for, is this randomized control trial. I suspect we're going to be hearing very soon. I would think that it ought to have the same impacts, and you'll see even there, you know, the long-term the variability in response, and I don't know that it's understood why it's variable. I've had a number of conversations. The company doesn't think that it's compliance with the medication, and so there are likely physiological differences in response. Whether that's from the etiology of obesity or not, I guess I don't know.
I think it is emotional too, because
Yeah,
depending on how, I don't think we ever really know, or we don't always know how challenging somebody's life might be inside. So, you know, I've had a kid where, you know, he lost significant amounts of weight just with metformin, but what happened was he became more social. So he was spending time with his friends and going out and being busy with his social life.
Yeah.
And probably was, when he wasn't doing that, was home alone, eating and playing video games. So I don't know if that's what it is, or if it's physiological or what. It's hard to say.
Interesting to talk on to the folks that look after adults, because a lot of them talk about the use of the GLP-1 analogs in terms of reducing that sort of craving, reducing the taking a bit of the top off the craving to eat, and so they've thought that maybe it is those with sort of emotional eating, those who have really a food addiction type of approaches, that this assists them in the individuals in managing those cravings better. And so I haven't seen good data to support that. It's been more of a sort of, this is what we think is happening. So I think that there's lots for us to learn here.
Excellent. Thank you. This is a great conversation. Wish we could keep going, but we do need to move on to the case presentation portion. So thank you so much, Dr. Morrison. We appreciate your time with us today, and thank you for the questions. I'll just send your attention over to the chat box. Christine added a nice little summary of finding Saxenda coverage. So